We want to begin again, try to get us back on schedule here. Before we start, just one thing, I do want to recognize Jeremy Romero, Public Safety Advisor to the Governor, is with us today. Jeremy, thank you for joining us today. Okay, our first panel, Frontline panelists. This is the public safety. These are the men and women on the streets. They're the people who see what's going on firsthand, all right? To lead us through this, you've probably seen him on TV. Dean Staley from Channel 13 is going to moderate this panel for us. Dean, have at it.
All right. Good morning. Can you hear me all right? We doing okay? Wow, there's some enthusiasm here. I like that. We've got it pumped up. A big thank you to everyone here. I'm really pleased to see the turnout. We've got some empty seats now. I know people are going to be filling back in here. A lot of people still taking a break. So I want to thank everyone for being here and showing interest in helping us solve this problem in our community. Bernalillo County and the city of Albuquerque with this massive coming together and all of the other partners to put this event together. So we're pleased to have you, and we're pleased to have our esteemed panel. I'd like to introduce the folks we're going to be talking to this morning. First of all, if you would, maybe raise your hand or stand up so people can see who you are. Get a sense of who's up on the panel. First of all, Dr. Daniel Duhigg, who's a member of Bernalillo County's Addiction Treatment Advisory Board. Dr. Duhigg is also the medical director for the Duke City Recovery Toolbox. Doctor, thanks for being here. Also, Dr. Brandon Warrick from the University of New Mexico. He's a board certified in medical toxicology, addiction medicine, as well as emergency medicine. We're glad to have you. Thanks for being here. We also have with us this morning Captain David Funes from the Bernalillo County Sheriff's Office, who served with the county for 19 years, one of the people who's been part of being on the front line of this battle against fentanyl addiction. Captain. Kyle Hartsock is the Deputy Commander for the Albuquerque Police Department. You probably recognize him. He spent a fair amount of time lately on television talking about different things in our city. Commander Hartsock has worked in criminal investigations since 2009, including time before at the Bernalillo County Sheriff's Office. So, Commander, thanks for being here. We also have with the Bernalillo County Fire Department Captain David Lujan, who oversees the EMS division, and that includes the oversight of 265 field personnel. Captain, thanks for being here. With Albuquerque Fire Rescue, we have the Deputy Chief of Emergency Services, Emily Jaramillo. We also have with us this morning Dr. Heather Jarrell, the Chief Medical Officer for the Office of the Medical Investigator. We have an addiction specialist, Dr. Sylvie Stacy, with the Metro Detention Center as well this morning. Also this morning, Kylie Schroeder, the Director of Prevention and Intervention Counseling at Albuquerque Public Schools. A big job. Yeah. So as we get started, I'd just like informationally to share with you where our questions have come from. We, in large part, came up with the questions this morning from the public. We also have questions that came from our panelists this morning because they felt there was something specific that they wanted to talk about and share with you this morning. And our panelists, in some cases, also shared questions that they routinely answer about fentanyl in our community. So they sort of raised their hand and said, we should talk about this because it seems like a lot of people are asking that. So some of the questions may seem simple, but we really are going to try to drill down and get to the bottom of a lot of things. There's a lot of, I think, ignorance about this problem in our community. So forgive us if some of these questions seem overly simple. There's a wide variety of them. So I want to start with Dr. Daniel Duhigg. Dr. Duhigg, first of all, if you could just talk to us about the mechanism of fentanyl and how it affects the body. Why it's so much more powerful than some of the other opioids that we've talked about. And also the question that was put in front of me, is addiction in fact really a medical illness? Please.
Thank you, Dean, and thank you everybody for coming here. Such an important community event So fentanyl was really designed as a stronger opioid, right? Opioids are a class that contain lots of different things that we're familiar with. Heroin, oxycodone, morphine, right? There are a large variety of these. And really, to the brain, they're all pretty similar. They differ in how strong they are and how long they last. And for a long time in medicine, fentanyl was a really helpful tool because it was strong, but didn't last too long. So we could use it for surgeries. We still do. We use it to treat people after serious injuries. The problem, of course, with anything that's this strong is when you have unregulated use, right? When we have versions of it that aren't made by real pharmaceutical companies that flood our communities. It's stronger than heroin. It's stronger than morphine. And part of the problem also is that, you know, when real pharmaceutical companies make medicines, they have quality control. They know how much medicine is in each tablet or each strip, and that's not the case here. And so while we can see that there's variation in how much fentanyl is in any pill, when somebody's using it out kind of on the street, they don't know that. As opposed to when I get a medicine from a pharmacy, I know exactly what's in it. How do they work? We have these receptors throughout our brain that we call mu-opioid receptors. It's just the name that we give to them. And they're totally important. They're where our endorphins work. They are part of the mechanism in our brain that drives its ability to take another breath, what we call the respiratory drive. And they're also involved with pain. This is why opioids can be used as medicines, but this is why they have the risks that they have, why they make our brain essentially forget to breathe, which is how I describe it to folks. And unfortunately, our body gets used to them. And it gets so used to these medicines or these drugs, if we take them every day or very frequently, that we have withdrawal, which many people have experienced or seen loved ones experience, right? When we're taking something like fentanyl day after day after day, it actually suppresses our adrenaline levels. And then when we run out, we get this huge wave of adrenaline. And that makes us anxious, that makes our heart rate go up, it makes us sweat. And then our pain levels now are out of control. And this is why people feel so sick. And it feels like it's an emergency. People will feel like they're going to die when they're going through opioid withdrawal. The good news is, most of them aren't. It's not dangerous in that sense, opioid withdrawal. What's dangerous is feeling so, such a sense of, I need to do something now, right? Feeling so desperate that then people maybe make decisions that put them at further risk. And I think for a long time, for your second part of your question, it's been, you know, the idea of addiction has kind of been outside of medicine. And I think for a lot of us, we see the choices that people make, and we say, well, it doesn't really seem like a disease. It seems like choices. But what we understand now is that there's a lot of genetics behind it. There's a lot of our DNA. It runs in families, not by accident, right? But because it's an illness, because it's in our genes, because it's biological, there's definitely choice. Just like in diabetes, we can be at risk for diabetes, and there are lots of choices about our diet and things. But there's choice and genetics. And we call that a disease. Addiction is absolutely a disease. If it wasn't, we wouldn't have doctors and other healthcare and frontline providers who are addressing it. It's a chronic disease. We have medicines for it, and we have other forms of non-medicine treatment. And because we get sometimes other medical problems associated with it, whether we've overdosed and it's hurt our brain because we weren't breathing, or from getting hepatitis C, or other things, there are other parts of it that we need to treat medically as well. So it's definitely a disease. It fits beautifully in the chronic disease model. And the good news from all of that is that we have treatment, and treatment works. Treatment absolutely works. It works if you work it.
On that topic, Doctor, is the treatment for fentanyl addiction different than for heroin or opioids, other opioids?
It's a great question. I would say that for the most part, it's not. Again, because to our brain, opioids are opioids. Our brain doesn't really know what they're called or what their chemical structure is. It responds. We have 3 medicines that are effective in treating opioid use disorder or an opioid addiction. Those are methadone, buprenorphine, which most of us know as Suboxone, and naltrexone. And these are the 3 medicines that work. Lots of science behind it. We know that when they're done the right way, they're safe and they are effective. So we don't really treat it that differently. Sometimes we might think about ourselves differently. I use fentanyl, I don't use heroin, or I use oxycodone, I don't use fentanyl. But the treatment is pretty similar. How much withdrawal you go through and how hard it is to tolerate, that can be different between the different substances. And that means that we maybe need to have a little bit more care and a little bit more patience and attention. But otherwise, the treatment really is the same. It's the good old treatments that we've been doing now since the late 1960s, and that we have a really good track record with, that we understand well, and that are safe and effective.
Doctor, on that point, is methadone as a treatment, some people talk about it just being a replacement, a sort of a new addiction. Is there a downside there?
So no, it really goes back to the whole definition of what is an addiction. And we have a medical definition. And I like to say that's when our relationship to a substance is getting in the way of our relationships, our safety, how we fulfill our roles or not. That's what an addiction is. So if I'm using fentanyl every day and I'm not fulfilling my roles and I'm not being safe and it's worsening my physical or my mental health, that's an addiction. If I get on a medicine like methadone or Suboxone or naltrexone and I'm taking those every day, and because they are controlling my addiction, I'm able to get a job and I'm earning back my family's trust and I'm safer and I'm getting my Hep C and my blood pressure taken care of, that's all upside. It's not replacing an addiction with an addiction. It is a similar type of medicine, but it goes back to that definition of addiction. Treatment is about being free from the problems that addiction treats or that addiction causes. And these medicines, when done correctly, absolutely help us find freedom.
Dr. Warrick, who among other things is a board-certified toxicologist, I have a question from the public, and that is, if someone doesn't use fentanyl or other drugs, should they worry about casual contact in public places like on a bus? Or, I mean, we've seen videos with officers exposed to fentanyl. Can you clear that up for us?
Yeah, thank you. This is an area where I've spent a lot of work on at the national level. And I'm just going to start my answer by going back to what Dr. Duhigg said. And fentanyl needs to get to the brain to cause you to become unresponsive, to make you stop breathing or for death. So while it gathers headlines saying, hey, this little tiny amount of fentanyl is enough to kill you, that small amount has to get into the brain. So me looking at fentanyl doesn't get into the brain. While there is some absorption that can happen through the skin, we've studied this going back to the early 1970s, and specifically Janssen Pharmaceutical, and we now have multiple companies that have a patch. What we know is that it takes hours, realistically a day or more, for that to be absorbed through the skin. Now, if you're injecting it through a vein, if you're smoking it, and like you would heroin or or snorting it like you are cocaine, that's getting into the body, that's getting into the brain. So the casual contact really that you get, the amount that you have to have, as I wrote in the position statement by the American College of Toxicology and American Academy of Toxicology, you have to essentially leave your hands, both of them, completely covered in a liquefied version of fentanyl that's been made to be able to absorb through the skin for hours, even to get to a therapeutic drug level. And that's just not realistic. And so in that, the position statement that I and my other colleagues wrote really became a foundation that would be later released by the White House involving more than a dozen medical and law enforcement organizations. I've also been a consultant for the Canadian government, setting a lot of their policy guidelines for how the Royal Canadian Mounted Police do this. And with that also comes access to knowing cases where somebody has gotten ill. There have been several that hit the TV people claiming an illness, but the illness they were not experiencing is not opioid related. I've also gone through scientifically looking for cases, published, unpublished cases, and presented them this fall, and I have identified 0 cases to date of an opioid directly causing illness. Who's become a friend, National Drug Coordinator of Royal Canadian Mounted Police, describes it as if bad guys ever had kryptonite for cops, they found it in fentanyl. So with that, one other thing is if you were to come in casual contact with it, it would be wash your hands. We've all got hand sanitizer up here. And remember, hand sanitizer is good for COVID. It's good for bacteria, virus, but it doesn't destroy, it doesn't neutralize, it doesn't kill fentanyl. So just soap and water is how I would get it off my hands.
Before we move on, and this may sound elementary, but I'd like to ask you, how exactly do people use fentanyl? How do they get it into their bodies typically?
Great question. So I think the most common right now that we see is depends on the form that it's coming in. And in Albuquerque, we're seeing it come in the counterfeit pills, and we're seeing it primarily in our heroin supply. And so people beginning usually will get the pills and they'll ingest it just like any other pill. And I think that because we're so used to taking an acetaminophen, an ibuprofen, an aspirin for a headache, or an antibiotic from the doctor for a pneumonia, is kind of having that pill feels almost safe. So to people, so they're willing to, and we're kind of accustomed to doing it, and there's that feeling of safety. What happens in the body is not all the fentanyl is absorbed or goes to the brain. We'll put it, that's an easier way to describe it. Medically, we say bioavailable. As they need to get a little bit more, their friend comes along and says, hey, you know what, if you crush and you snort this, or you smoke this, it goes to the lungs, gets absorbed fairly rapidly, goes to the brain rapidly, and that is oftentimes what gives you that euphoric effect. And we're able to get more of the drug to the brain, and so they start making that switch. And then after a period of time comes along, they're like, man, I'm out of money, I'm working really hard, my family doesn't want to do this, and then their friend, and in Mexico, and in the country, family members too, comes along and says, hey, you know, if you inject this, the drug goes even further than it does in the lungs, and they make the conversion to injecting. So those are kind of the ways that we have that people are abusing or misusing it. But I've never had a case, and if anybody else has, I would love to know about it, where somebody is actually abusing, misusing fentanyl by just putting the powder on their skin. I have had the fentanyl patches where they cut it up and they'll suck on it and things like that, but I've never seen anybody or heard of anybody putting just the white powder on their skin because it just doesn't get absorbed fast enough.
Doctor, thank you. This question for Captain David Funes. Captain, a longtime lawman with Bernalillo County. When an emergency call goes out for an overdose, does law enforcement automatically respond to that, and if so, why?
Yes, sir. Law enforcement does respond to all overdoses, and the purpose for that is for scene security. A lot of the times when there is an overdose, it is the family or friends of the person who was overdosed that is making the call. And when we arrive on scene, sometimes those family or friends are frantic, of course, and they don't want to leave the side of the patient. We respond to ensure that the scene is safe and secure and provide an area where rescue or emergency medical personnel could render aid. We're not necessarily there to take law enforcement action, and there is laws, Good Samaritan laws, that protect both the caller and the person who has overdosed from being arrested for possession of drugs.
Captain, thank you. And let me just take a moment to ask all of our panelists, if you feel like there's something more you'd like to add to any of these answers, please do. I would love for this to be more of a discussion than an interrogation, so feel free. Captain, I have another question for you. Officers are often the very first people to show up in the case of an overdose. Are all of your deputies trained in aiding overdose victims?
Yes, sir. Primary mission of the Sheriff's Office is to preserve life, and part of that is getting trained on basic first aid, and all deputies are also trained in and equipped with intranasal naloxone for opiate overdose. And they're trained to administer this naloxone until rescue could show up on scene and actually take over their treatment.
All right, Captain, thank you. Commander Hartsock, where does fentanyl rank with other drugs in terms of use and prevalence in the metro?
You know, what our officers and our detectives see is why we can't always say overall what percentage of the drug use market is fentanyl. We could definitely say its popularity is on the rise, much more aggressive than any other drug in Albuquerque. And we attribute that to a few things. One is this drug, and the doctors and the DEA spoke about it as well perfectly. It's not like our other drugs. The barrier to use this drug just by appearance alone is so much lower, so much easier. It's not heroin burnt in a spoon, loaded into a syringe, injected into our arm, which for a lot of people can cause just a psychological barrier where I'm just not going to do that, I'm not going to try that. These counterfeit pills look pharmaceutically manufactured. In a lot of cases they are, and they're as easy to take as an Advil. You might even think it's an Advil. I can recall even a time on an operation I was doing, I was pretending to be a drug user buying fentanyl online, and we did buy the fentanyl, and later on the drug dealer actually, it was a girl, she checked in on me to see how I liked the drug. And I told her earlier, this was in 2018, yeah, I just took it with like a shot. And she was really concerned. She tried to call me on Snapchat, and I was like, nope, not answering your call. She was worried I took this pill the wrong way, that it was way more powerful than I thought it was, and that I was more loosely just popping this fentanyl pill and drinking alcohol. And she was actually concerned about what would happen and started asking me what my fentanyl history was. So it was a really enlightening experience that I wasn't used to seeing from drug dealers and this type of drug. So its appearance alone, I think, just makes it so much easier for people to maybe try and stay on because it can fit in with a prescription from Walgreens or CVS to the untrained eye.
Captain Lujan, who in our community, and I'm talking about demographically speaking, in your experience, who's using fentanyl?
Well, what we've found, obviously through our report writing and our statistical values, is we found that fentanyl, it doesn't discriminate against anybody. We're seeing it through different races. We're seeing it through different socioeconomic populations. When we look at our numbers, they can be a bit misleading for us. The only way we're able to evaluate these things is through our Narcan use. So it typically is, it's not necessarily specific to fentanyl. It's just opioids in general. So anytime that our crews go out and administer Narcan, we chalk that up as a potential fentanyl use. It could be heroin, it could be morphine. But we're seeing it across the board. We're seeing it, what we call our north region, which encompasses the North Albuquerque area, North Albuquerque Acres area. We're seeing it down in the south region, the South Valley. We're seeing it up in the East Mountains. So it crosses all boundaries at this point. We're not necessarily specific on, was it fentanyl, was it heroin? It's the way we document these things was Narcan administered. And just as Captain Funes indicated, sometimes our deputies arrive on scene and administer Narcan before we do. So we go in and make sure that we document that appropriately. Sometimes we're seeing the calling parties actually administer Narcan, and it's one of our goals is to try to document that in that capacity. So just know that it's not specific to a particular race. It's not specific to a socioeconomic population. It is across the board.
Captain Lujan, thank you. I'd like to ask your counterpart, your colleague at Albuquerque Fire Rescue, Deputy Chief Jaramillo, what fentanyl-related trends is AFR seeing in the metro?
Hi, thank you for that question. Just to reiterate what the captain said, we've seen similar trends. I did write some of our data down just because I think the numbers are pretty telling. Where we noticed this is about 6 months into the beginning of COVID. I had a conversation with our medical director, Dr. Kimberly Pruitt, about how we were so focused on COVID, and we were noticing increased calls for overdose and increased calls for death related to overdose, and that nobody was really talking about it back then because we were so preoccupied with COVID. So a lot of these numbers we pulled from the past year, and in the past calendar year, from October 21 to September of 2022, we responded to roughly 1,600 deaths. And of those, 942 were obvious. This is an increased rate in obvious deaths that we're seeing at Albuquerque Fire. A lot of this is anecdotal. We obviously don't always know why somebody dies, but we are seeing these increased obvious deaths. One of the alarming trends that we've noticed in the past, I would say 3 to 4 years, is that we have more people dying in that death rate age 59 and under. So of that roughly 1,600 deaths, we had 842 were 59 and under, and 753 were ages 60 and up. So with that age group being so young, and with the increased fentanyl in our community and our increased overdose rates, we're seeing higher death rates related to fentanyl. The other alarming trend that we've seen is related to pediatric exposure to fentanyl. And so in that same year of data that we ran, we gave Narcan 68 times to children under the age of 1. And 23 of our calls for the same age group under the age of 1, our providers on scene declared in their charting that that was an overdose. So, that's pretty alarming to us, that young children are getting into their parents or their caregivers' fentanyl, and we're seeing that in our responses. To further break down the pediatric rates that we're seeing in our community, we gave out Narcan 730 times over that calendar year, which is higher than we've done in the past, but you also have to consider that we have Narcan more readily available than the public. So those rates are probably much higher than we're seeing in 911 because people are administering Narcan and not calling us. So we expect those rates to be much higher than what we have. But of those 730 administrations, 157 of the administrations were to youth ages 0 to 20. And so that breaks it down to 22% of the time that AFR administered Narcan last year, or over the past 12 months, it's been to somebody under the age of 20. And so we really feel like not only is it alarming that we're seeing higher rates of death related to fentanyl in our community, but particularly the rates for pediatric.
Chief, thank you. Captain Lujan, can you speak to us about the difference between the increase in fentanyl overdoses versus heroin?
Yeah, so again, in our report writing system, we're actually building, because again, we're seeing this more often, we're building where if there's some indication that we know it's fentanyl, we actually have our crews go in and check that box versus heroin, just because we want to see what that discrepancy is. Basically, kind of reiterate what Chief Jaramillo was talking about. For our department, from basically January of 2022 to present, we've given Narcan 216 times. Understanding our demographics are slightly different because we serve the unincorporated area of Bernalillo County. So for us, that's actually fairly high. With that being said, I can't be specific on the numbers because of the way we have to redact that information, but we're just seeing a higher increase in fentanyl use with administration of Narcan. So at this point, with just kind of having the raw data, basically it's about a 20% increase in fentanyl use with the delivery of Narcan. So that's where Bernalillo County is seeing that.
Deputy Chief Jaramillo, what is AFR doing to manage, to react to the issues we're seeing related to fentanyl?
So aside from the obvious, we respond out if a call comes in through 911 for somebody that's overdosed. We've really embraced harm reduction as well. So we have a community paramedic team that was established by Mayor Keller the first year of his term. It's called the HEART team. And we have a harm reduction program within our community paramedic group of firefighters. And we've included several programs with that. One of them is that when somebody does overdose, we provide follow-up after the overdose with our community paramedics. That includes following up with the family and then also referral to a peer. We had 2 peers on our team that had lived experience recovering from addiction. We subsequently lost our 2 peers, but now we are able to refer our clients to work with peers within the ACS department in the city. Another harm reduction program that AFR has implemented over the past year is Leave Behind Narcan. So each of our field responder, each truck carries a Leave Behind Narcan kit. And when we respond out to an overdose, we are able to educate the family and friends that are there on scene with the individual that overdosed. We leave Narcan behind, we show them how to use it, and we provide materials that if the family member wants to seek out treatment options, we can help refer them to that. And so we're really looking at it from that harm reduction standpoint of we've responded out to you for an overdose, we want to help your family in the event that this happens again. And so that's something that we've had a lot of success with over the past year. And then another important piece of that is just collaborating with all of our partners that are up here, as well as a lot of the other departments that are represented here.
Chief Jaramillo, thoughts about how we can improve, what we can do better, what more we can do to battle fentanyl?
I think our biggest ask is just increased awareness, especially with youth and use among youth. And so the more that we educate our community into the dangers of it, the importance of Narcan, and just that will help, and just helping to destigmatize it as well. We see a lot of, when we respond out to a family where their child may have ingested fentanyl or some type of opiate, they're afraid to share that information with us. So they may say, they may call it in as a seizure for their child when it's really an overdose, and then we have to use the process of elimination to effectively treat that with Narcan. Because the first thing when you respond to a 1-year-old is not, I need to give this kid Narcan to get him breathing again. And so if the family can disclose that to us, we can treat them quicker. So the biggest thing that we would like to see is awareness and education for the community, and then also just increased access for treatment. This state and the city could use much more access for treatment.
Can I piggyback
Please.
on that? One of the main reasons to put on this summit was to increase the awareness that was just talked about. And, I think all of us, we hear heroin and we think like, that's got risks, right? I think that there are a lot of families and a lot of parents and a lot of aunts and uncles out there who know to talk to young people about heroin, and maybe through the opioid epidemic have learned to talk to them about some pills. Part of what we really want to do is increase everybody's vocabulary about blues, right? These pills typically have a blue hue, so they're referred to as blues. I think we all need to be talking about blues. We all need to be talking to our kids. The question that came up about, how is it used, I wonder if we could put the image back up. We wanted to share, for example, with everybody images of things to look out for, right? Because again, if we see a syringe, we think maybe somebody was shooting up with this. But in your household or in your community, if you see foil that's crunched up, foil that has burn marks on it, like tinfoil, that has brown smudges or dark smudges on it, foil that smells bad, this should be as alarming to you as finding a syringe in your community or your household as well. This is really what we need people to be talking about, and especially to youngsters. Pills can't be trusted unless we know where they came from. And little things like foil mean much more than just foil. That's really what we need to, I think, talk about. And I think it's linked to kind of the same question about these trends, right? People tell me, I get the benefit of talking to the real experts every day, which are patients and people who are living with addictions. And a lot of them tell me that it's hard to find heroin. these days. The marketplace is changing. All the heroin, or almost all of it, was coming from the Sinaloa cartel that we heard about earlier. They just changed their product. They switched it from heroin to fentanyl because they don't have to deal with growing seasons to grow heroin, right? They just make this stuff year-round and bring it up into our communities. So we will continue, I think, to see less and less heroin. The prescribers, we've tried to really take care of our part of overprescribing opiate pain pills, the legitimate pills. But now it's the fentanyl pills. So we all need to talk about blues, and we need to look for signs other than just syringes.
Doctor, thank you. Some great counsel there. Commander Hartsock, I'd like to ask you, staying in this vein, there's sort of the basics here. How are people in our community buying fentanyl?
I mean, the traditional way to buy drugs is still around, right? You know a guy who knows a guy, and you can just connect with him, right? But the days of just driving down kind of maybe a drug house street, pulling up to the front, knocking on the door, those are going away, right? That's really, really high risk. What you're seeing now, and I'll just show it up on my phone and you can zoom in, but here's what social media is going to show, is here's just a bag of the blue pills, right? And if you can't read it just yet, it says tap in, right? Tap in is meaning, hey, hit me up, get some of this, I got you. What you're also going to see is just, and you saw it on the DA presentation, but here is a literal menu of drugs. I'm at Corizon Paseo, I'm mobile, here's a list of everything I have, I can just come meet you. And instead of having to know a guy who knows a guy, now you can just get on social media and virtually any of the platforms, by the way, Facebook Messenger, Snapchat. This guy even says, I'm also on Instagram. I mean, he is marketing like it's an Etsy store selling crafts, but he is selling drugs, right? That you can get these things. And to point out what the doctor said too, what we also see vastly moving is the use of emojis to describe drugs. Does anyone know what this emoji is on every phone in this room? Whether you have an iPhone, an Android, Samsung, you have this in your list. Does anyone know what this, like why did Apple design this emoji? It's used for fentanyl drugs, but anyone know why they actually designed it?
Metro?
Yeah, it's the Metro. It's the train, right? The Metro is a common term to describe underground trains in certain urban areas. It's the Metro. But when we see it, we know this means this person is trying to sell or advertise the fact they have fentanyl pills. They do this with all the drugs. Cocaine as a snowman or a snowflake, right? Marijuana, although now mostly legal, was a tree, right? It was called trees. So we see entire advertising posts for anyone who has access to their cell phone to get virtually any drug they want. The barrier is really low. And we also see that feed into our violent crime trends as well.
Commander Hartsock, tell us, how is fentanyl linked to other crimes in the community? It's clearly part of creating other issues for us.
Absolutely. One of our biggest crime categories for our homicide rate, which has increased year over year for the past 3 years, is robberies. And it's not the robbery of the Allsup's clerk or the Walgreens, it is the robbery of a drug dealer or a gun dealer. Or it's the robbery of in the reverse way. They're pretending to be the drug dealer and they want to rip off the guy who has the money to come. Because both parties know this is inherently illegal what we're doing, there's a low likelihood that police are going to get called or intervene in this. This is not a legitimate business to start with, which opens it up for people looking to take from others with violence. And we see a lot of these turn to everybody's armed. Everyone brings guns to these things. So our second biggest category for motivations and murders right now in the city of Albuquerque is drug deal robberies. The number one drug of choice that we see in virtually all of these robberies is fentanyl by a large margin. Doesn't always associate with user, but I can tell you fentanyl pills, they call them boats if you got 1,000 pills. They say, I want a boat of fentanyl, right? And I don't mind sharing these terms with you guys. I think everybody should know these terms. So that means, hey, you're going to bring 1,000 pills. That's a lot of resale value I can get. There's also a certain amount of I took from you, right? It's respect, it's disrespect. So there's lots of these motives that come in, and these robberies can turn very deadly very fast. And a lot of families have lost their children to these types of robberies. And I want to point out APD's Victim Services Unit right here. Will you guys stand up real quick? These women, this team is just growing. They work inside our homicide unit and our CID. But I hope this is the only time you get to meet them. Because if you have to see them again, it's most likely that someone close in your life has been killed. That is who they work with day in and day out, and I'm proud that they're here to learn more about fentanyl. But we see it tied to many crimes. And I also want to comment, too, on the pharmaceutical versus this. You know, our country, I think we shouldn't ignore it, also went through a span of 10 to 15 years where prescription medication was overprescribed, right? I think the DEA led the charge into a lot of that, into pharmacies overprescribing legitimate pain medication that, yes, that might get curbed now, but it left a void. And I'm seeing the DEA nodding their head, which makes me feel good. I'm saying this unscripted. The void is getting filled. So I think that's important to acknowledge as well.
Commander, I want to just go back at this for a moment. So if we're talking about 100, it's just a rough number, 100 murders in the metro.
We have 102 right now,
Right.
if you want
Well, I
to
hate
use a real number.
I don't want to
yeah.
bring it up. How many are we talking related to fentanyl? You're talking about robberies, you're talking about drug deals. Give us a number, a rough number.
Yeah, I mean, the robbery number.
It's such a serious problem here in New Mexico that we have changed the way and previous dying from a drug overdose received an autopsy. The numbers are so staggering that we cannot keep up with the volume. The preliminary, there's some provisional data on drug overdose. There's about an 84% increase in fentanyl analog deaths from December 2021. Which is pretty staggering. So we change the way we practice. Number one, we have a postmortem CT, or we have a CT scanner. Nearly every decedent who comes to the office of the medical investigator or the medical examiner's office gets a full body CT. We can then utilize what we're seeing on CT as well as what we're seeing on scene, because we send an investigator out to the scene with law enforcement and with other first responders who are there, have a look around, document what we see, and then the doctors make a decision. Are we going to do an autopsy, or are we going to just do what we call an external examination and not open the body? And we can usually make that decision based on what we're seeing on CT. We also can get a urine drug screen sometimes and get an idea of whether illicit drugs are on board. And based on what we're seeing, sometimes we elect not to perform an autopsy and just do an external examination with CT and a full toxicological profile. If we do an autopsy, sometimes the fentanyl acts so rapidly that it's not going to show up in urine. And sometimes the fentanyl acts so rapidly that you don't have time to get brain swelling or fluid in your lungs. You just die. And the fentanyl that we see is staggering. We mentioned the lethal concentration. I've seen concentrations as high as 20. And I have no idea how the person survived long enough to get to a concentration that high. So that's what we're seeing on autopsy. We're seeing fluid in the lungs and brain swelling.
Dr. Jarrell, thank you. You mentioned your office is not only involved in the investigation of the condition of the body, but also the scene, the circumstances around the death. Can you share with us some of the common findings that you find at scenes where you have fentanyl deaths?
Yes, that's a great question. We sit in morning report, and our taking photos of when they go to the scene. I can't tell you how many times a day we see the photos of the aluminum foil squares with the burn marks on them. Lighters present. Sometimes we see cut straws. Sometimes we see powder on scene, and we see the blue pills frequently. If the blue pills are on the body, whatever is on the body is our jurisdiction, and that comes in with the body. So we go through everything in the pockets and take that out. We see the blue pills frequently. And so we're seeing those things on scene. I neglected to mention that many times we can, depending on how the drug is administered, we can see foreign material in the lungs. If it depends on how it's administered again, whether it's injected or whether it's snorted through a straw or however, we can see that in the lungs. And so those are the common findings that we're seeing on scene. The burned foil is frequent.
Dr. Jarrell, thank you. I'd like to shift a little bit of our attention to how fentanyl is affecting some of the other institutions in our community. We have with us this morning Dr. Sylvie Stacy, an addiction specialist at the Metro Detention Center. Thanks for being here. Clearly, a whole different set of problems that comes with fentanyl. Can you tell us what the challenges are of fentanyl use inside a correctional setting?
Yes, so I would say one of the major challenges is quickly and effectively identifying the individuals who have been using fentanyl when they are arrested and come into the facility. And the reason that's so important is twofold. First, patients who have been using fentanyl for any period of time longer than a couple of weeks will have a physical dependency on fentanyl, and when they're arrested, they're suddenly cut off from that supply of fentanyl that they've been using, and they're at risk of what can be a pretty severe and uncomfortable withdrawal symptom. And it's mostly symptoms that are just very uncomfortable for the patient, but there can be medical complications such as dehydration that need to be treated. And then the second reason is being in jail actually represents a pretty unique opportunity for us to actually link a patient up to treatment for what is most likely an opioid use disorder. So we want to be able to identify the patients right off the bat who may benefit from that and either get them started right there in the facility or provide them resources as to where they can get treatment once they're released from the jail. But as you can imagine, jails themselves are not primarily places to receive medical care. That's not the reason that jails are designed. They're designed for public safety. So the way that we've addressed needing to get information from patients up front is we actually have a nurse that one of the very first things that happens to a person when they're arrested is they'll see one of our nurses at the intake area who takes the medical history, which includes several questions about their substance use history, in particular fentanyl. And when we gather that information, we're then able to start any treatment that is needed and start that process of linking them up with the treatment that they need. But as you can imagine, when a patient is arrested, it's a pretty stressful situation. They may be hesitant to provide information about their drug use, being concerned that it may be used against them. So we stress to patients that they have a right to medical care when they're in the facility. So if they have high blood pressure, we'll treat their high blood pressure. If they have diabetes, we'll treat their diabetes. And really, fentanyl use is no different. If they have an opioid use disorder, it's our responsibility as healthcare professionals to treat that. So we always try to ask those questions in a non-judgmental way and get information that is going to be helpful to us to be able to treat them as effectively as possible right off the bat. And what we're finding is that about 21% of the patients that come to us are reporting fentanyl use. So 1 out of every 5 folks who are arrested and come through the walls of Metropolitan Detention Center are reporting fentanyl use. So another challenge is just the sheer volume of patients that require frequent follow-up to monitor for that withdrawal symptom and to get resources to make sure that they're started on treatment.
Doctor, you're among these folks on the front lines of this epidemic. How does fentanyl use and its detox differ from other substances?
So what the experience of myself and my colleagues has been is that withdrawal from fentanyl tends to be somewhat more severe and longer lasting than what we see with other opioids, such as opioid pain pills or heroin. And at this point, there are no published medical guidelines as to how it should be treated differently. As Dr. Duhigg mentioned, right now we're treating fentanyl use very, very similar to the way that we treat use of other opioids. But as medical providers, we like to practice what we call evidence-based medicine, which is making treatment decisions based on clinical or scientific research that has demonstrated that it works. And so we're seeing that fentanyl acts somewhat differently than other opioids, but we don't yet have solid scientific evidence to support treating withdrawal or treating the opioid use disorder any differently than we do for other opioids.
Doctor, can you share with some of the common experiences that you're hearing from fentanyl users when you talk to them, what their experiences are?
I'd say one of the most common ones that it's always striking when I hear it is that patients increasingly are not fully aware of what opioids that they're using. I've had many patients who believe that they're using heroin and are pretty shocked to learn that we've identified fentanyl in their urine. And with so many analogs of fentanyl becoming available and the actual product that they're using constantly changing, it's almost like even if they tried, they couldn't necessarily know exactly what it is that they're using. And that, combined with the fact that it is often mixed in with other illicit substances such as methamphetamine or other types of opioids or Xanax, patients are often using multiple substances at the same time. They're not able to provide a really accurate medical history such that it presents a challenge to healthcare providers to really tease out what may be going on when they're presenting with either symptoms of intoxication or withdrawal.
Doctor, thank you very much. We have another massive institution in the metro, Albuquerque Public Schools, that is dealing with this fentanyl crisis. We have with us Kylie Schroeder, who's the Director of Prevention and Intervention Counseling at APS. If you would, can you tell us what effects from the fentanyl epidemic you're seeing now in the schools?
So this is really interesting because I'm going to answer that question by telling you all what we're not seeing. What we're not seeing is we're not seeing students in the bathroom taking fentanyl. That is not what we're seeing. We are not seeing students overdosing in our school. It's very interesting because what we see is indirect more than direct. So when we say we're on the front line, we're not on the front line with visually seeing students using. What we're seeing is the emotional impact of family use. We're seeing, unfortunately, we often don't even know students are using until we get a call that a student is in the hospital in a coma or has passed, and we don't always know the cause of death. It's anecdotal. So therefore, it's not like I can give you statistics on how many students have died from a fentanyl poisoning or overdose. But the emotional impact of family use we see with our students. We have, you know, it was really interesting. I talked with one of my counselors last week, and she was meeting with an elementary student who was very dysregulated, very upset. And why? What's going on? He said, well, the fentanyl got my uncle. So there's this discussion that it's like the boogeyman for kids, that they don't understand, but they know that there's this thing out there that is taking away from them people in their family, people that they love, people that they care about. So we see problems with attendance, we see behavior changes, we see all the things that we see for other reasons also, but it's the impact in the community. It comes to our kids. Our kids are, even if they're not the ones using, it's the family members, and it's the impact of the family on our students. Just yesterday, I got a phone call from one of my counselors at one of our high schools who didn't know who this student was, but had been notified that he had purchased 3 pills at school. Okay, so we know that there's access and we know that it's happening. It's just not out there like THC use. And I'm just going to put that out there because that's what's happening in the bathrooms. But with fentanyl, this student bought 3 pills, took 3/4 of 1 pill, and it put him in a coma. And the thing is, my counselor, who one of the programs that I support is called Crossroads. And Crossroads is, we have master's level counselors who have additional training in substance use and misuse. And the counselor, my Crossroads counselor at this school, didn't know that student. It's not like when students get busted in a bathroom or using on campus, then our counselors, our Crossroads counselors, are involved and they become aware of these students that are using, and then they use harm reduction and they meet with students. But what's happening with the fentanyl use is we don't find out until after something has happened. We don't have the ability to know. She didn't know this student because they were like, well, we don't know what happened, but he got a hold of these pills on campus. So what we're seeing is it's a mix. You know, we're not set in the front lines per se seeing it happen. We know it's happening, and we need to, you know, they're raising this awareness and having the conversation in the community and having parents not be afraid to talk about it. All those things are connected, and just being up here and being a part of this is pretty amazing. I don't know about you all out there, but just hearing the knowledge up here and what everyone is seeing is, you know, I'm horrified at when I got that call yesterday about this student being in a coma. Of course, as a parent, I can't imagine what that would be like. And the interesting thing is that they tested the 3 pills, and the 3 pills had varying doses or amounts of fentanyl in it. And he unfortunately took the 3/4 of the one that had the most in it. So that kind of supports what everyone's saying, that, you know, trying to educate our kids, but we have to go about this. It's really different with fentanyl than it is with the other substances that teenagers and, you know, are using. We're trying to identify how to do that and raising awareness and having families and communities not be afraid to talk about it is something that is definitely high on our list for what we need to do.
Please.
If I may add something to that, while she was speaking, it made me think of another kind of concurrent issue that we have in our community is just when we talk about accessing healthcare and education, we have other issues with health literacy and with language barriers and how people access their healthcare in our community. And so when we're talking about educating our community members in Bernalillo County and in our city and in our state, I think it's also important to understand that we have to tailor that message so that it gets out to the entire community, because just like Captain Lujan said, this is something that touches all quadrants of our city, but we also have to make sure that whatever education we're putting out and how we're educating our parents and our children and people is that it doesn't fail to educate you because of the language you speak or your immigration status or any of those types of things that might be a barrier to accessing health care or that education.
Dr. Warrick, you had a thought?
Yeah, I just wanted to say thank you for that. It's been, and extending on this, I think one of the things that we see at UNM's addiction clinic, we have a STAR program where we treat teens, young adults. One of the things that is really striking to me is that our teens find it to have easier access to methamphetamine, to fentanyl, than they do to alcohol and even to cigarettes. I have more teens drinking hand sanitizer than I do like drinking bourbon or whiskey or beer as their source of substance use and its availability. And I think with Commander Hartsock, it points out how pervasive and easy the selling is through social media. Also, by the time you get to law enforcement, it's a friend of a friend to distance themselves. But these are oftentimes family members or their actual friends that are providing, and they're selling, they're using together. Also, the price of fentanyl has dropped dramatically during the COVID epidemic. I think there was a day 5 years ago where it was $1 a milligram is the historic price of oxycodone. We went into the epidemic, I want to say about $20 a pill. Now, I haven't heard anybody buying a pill of fentanyl for more than $5 for a long time. I'm hearing reports that people are paying as low as 50 cents for the pills now. And to me, 50 cents, that's enough for a kid, usually a high schooler, but middle schooler with just lunch money is enough to get addicted. But looking at the numbers on how much fentanyl costs to manufacture and to put together, there is still more money in the fentanyl, the counterfeit pills by a long margin than there ever was in heroin or there is in methamphetamine. The drug dealers have room to go down in their margins by another factor of 10, which is particularly scary to me. And again, I think this is a place to share knowledge with people. I'm not trying to scare people, but these are numbers with my 10-year-old that keep me up at night. But I think it's great that we're working together and coming together with law enforcement, with medicine, with the city, with all of you also to try to impact this.
Dr. Warrick, thank you. Commander Hartsock?
Yeah, and I appreciate the insight to the schools. And a question I get asked a lot, and I've been investigating internet crimes against children with child exploitation for nearly a decade. When we talk about the drugs on here, I get asked a lot, what can parents do? What software can I download? What firewalls can I put in place? And I'll tell you, there is no better recipe than just talking with your kids and understanding them, and understanding the cadence of your child or your sibling or your cousin or your loved one, right? When something is off in their life, you should be close enough to them, ideally, that you can kind of detect it and dig into it. It doesn't mean it's fentanyl. It could be something else. But you want to try to understand what that stress is in their life, because I've talked to high schoolers and middle schoolers about when they're going through their apps, there's nothing really out there that can prevent them from seeing something that scares them, or seeing something that really just might interest them. And their brains at that stage of development, it's gonna pique their interest. They might want to learn more. The only question is, are you gonna let the app and their friends teach them, or are you gonna help guide them through it? So communication with your kids is always preferred. Yes, you can unlock their phones and go through their text messages. You can do that. That can come at a cost with your teenagers. It can, right? And you might win that one battle, but you might definitely lose the war of trust. But if you have trust with your kids and you have those conversations, you'll actually get to the deeper roots of why they were interested in it in the first place. So I also can't encourage that enough. But use your school counselors and resources. Use your community members to help build up that trust and that knowledge base. And don't be afraid to learn their apps as well. The best thing I did with the teenagers in my house, I just joined Snapchat and started talking to them on it. It's not that scary. It's actually pretty fun. You can do goofy filters on your face and snap, there's all kinds of stuff.
Settle down.
Yeah. One thing I'll tell you about Snapchat, they told us recently, they are taking a pretty hard stand against drug dealers on their app. If they see fentanyl in a user's account, and we see this, by the way, in our investigations, Snapchat just kills the account. They just send a message to the user and they say, you violated the terms of use, goodbye. And most of the fentanyl dealers aren't going through the arbitration process with Snap Media out of California to restart their account. But I'll warn you guys right now, the app we're seeing is now Telegram. And most of you might not have even heard of the app Telegram, by the way, but I'm glad you're hearing it now. It's a messaging app. It's not based in the United States. They're not subject to any of our legal orders or search warrants. But most of the party groups are now using Telegram to advertise parties, drugs. We've seen them now shift. So we can get mad at Snapchat, we can pile on them, sure, but the second they move them off, they just move to an app that's actually harder for law enforcement to track. So it's kind of one of those, be careful what you wish for, you might get it.
We only have time for a couple more questions. I just want to take a moment to thank Ms. Schroeder for, as someone who's a product of Albuquerque Public Schools, and I have a 10 and a 12-year-old in APS right now. I want to thank you personally for your efforts in prevention and intervention in those schools. I know it's a tough job, and we appreciate the work.
Thank you. You know, I do want to say that APS, yes, I'm going to put a plug in for APS for the school district. It's amazing because we have 13 high schools and we have 13 dedicated Crossroads counselors at each of those schools. There are districts across the country that don't have that, in this state that don't have that. So I'm very proud of the team that we have, of the knowledge. They stay up to date on everything. They keep collections of things that come across to educate other people, other staff members in our schools. And I am just so impressed with them and the fact that we have them as a resource and that they are so connected and that they are there to help. So I just had to put that in. Thank you for that.
Thank you. Dr. Warrick, I'd like to go back to you. We have just two more questions here. An important question, what can I do to help my community? Everyone here wants to help. We want to change this. We want to fix this. Tell us what you think we can do.
Sure. I think number one is the fact that you guys are here, and I want to applaud you for showing an interest and for allowing us to raise awareness. Second is, I want to also thank and appreciate all the people in law enforcement who are, and a lot, including the retired people, who've dedicated a tremendous amount of their career to trying to control the drug problem. I think it's time that medicine has steps up. We are more engaging in treatment, and we have those accesses. Interestingly enough, I think a lot of the people who have a substance abuse problem have a fairly decent idea about treatment. For families, I just want to put a plug in for Al-Anon. It's a nonprofit organization. It's on the Alcoholics Anonymous, Narcotics Anonymous family of things, but to support family members, because I think that's a lot of my questions from the public is, how do I get help? How do I navigate this? And I think that's a good resource that's a low cost. I just want to say at UNM, we're engaging in clinical trials and research. If anybody has a loved one, anybody has a member, a family member, friend who wants to, we've got a clinical trial paid for by the federal government or sponsored by NIH or specifically NIDA, National Institute on Drug Abuse, where we're looking for people to enroll and given a choice of either buprenorphine or naltrexone, and to do that. And I think it's important that federal tax dollars come to New Mexico and that we are part of the answer at a national level on how, because our population of New Mexico is not that of Boston, Massachusetts. It's not the same as New York City. We have a problem here. And so we're very interested in engaging and working with those people as well.
Doctor, thank you. We got one last question. I'd like to bring it back to the individual now. For anyone here, I have a friend or I have a family member who's addicted. What's the best thing I can do?
If I may, so encourage them to seek out treatment, and encourage them nicely. All right? You may be scared, and that may come out as anger, but they may misinterpret that, right? So I love you. I want you to get better. Encourage them. If they need a ride either to a meeting or to a clinic, please help them out. And I would really urge you, we talked about these 3 medicines, methadone, Suboxone, and naltrexone. I would really encourage you, don't tell anybody that any of them are bad, right? Even if they didn't work for you, even if you have your own views about them, we want all doors to be open. We know that all 3 of those save lives. So the best thing we can do is encourage anybody who's willing to get that treatment, any of those treatments, to get them and to stay on them. That's the best thing that we can do.
And if I could just fundamentally emphasize, Dr. Duhigg, is approach them with love, caring, help them make that phone call. That is so hard. There's so much stigma to make a call to an addiction center, because I now am an addict. I'm that junkie who's on the street, is what's going through their mind. And be like, no, you're not. We're going to get this so you don't become that person, but help them move along. But we can't enable them to keep coming back, but you really help them with those phone calls, really do a lot of positive reinforcement when they're moving in that direction.
Doctor, thank you. And with that, I'd like to thank everyone here. A fantastic turnout. It's great to see so many faces here. A big thank you to our esteemed panel, not just for sharing all of their years of education, also their decades of experience. And most of all, I think their dedication to rising to this challenge to try to solve this problem in our community. We thank you so much.
Thank you.
Also, before you quit applauding, Dean, thank you so much for doing this. You all know Dean Staley on television. He gives his time to come out here because, like the rest of you, he cares about his community, and I think that's very important.